Hello, my name is Kassandra Romas and welcome to 30 Medical Minutes. Our topic today is a serious one. We will be talking to Dr. Bertram Chinn, a surgeon who is chief of the Colon and Rectal Department at Overlook Medical Center in Summit, New Jersey. Yes, our subject today is colorectal cancer, also known as bowel cancer, colon cancer, or rectal cancer. It has been noted that 1 in 21 men and 1 in 23 women in the United States will develop colorectal cancer during their lifetime. It is the second leading cause of cancer death in women and the third for men. However, due to advances in screening techniques and improvements in treatments, the death rate from colorectal cancer has been falling. Dr. Chinn will describe what colon and rectal cancers are, that tumors may be benign or non-cancerous or malignant. He will also describe risk factors, symptoms, screening processes, and treatments available. This is a most valuable show for all, so stay tuned. And now let's welcome Dr. Bertram Chinn to 30 Medical Minutes. Welcome, Dr. Chinn. That is a lot. But it's a pleasure to have you here on 30 Medical Minutes.
Thank you, Cassandra. It's really an honor to be here, particularly because your show has enlightened so many people in the communities about health improvement and preventative health care too. So it's a pleasure to be here to talk about colon and rectal cancer.
Well, thank you so much. I really appreciate that. I appreciate your being here. Our purpose has been one of community service to educate our public, and to have you say that is definitely making me feel most flattered and honored as well. Okay, Dr. Chinn, tell us a little bit about yourself, your practice, and your background.
Sure. So at Overlook, we're very fortunate to have one of the largest departments of colon and rectal surgery throughout the state of New Jersey. We have many board-certified colon and rectal surgeons who are initially trained as general surgeons who have gone on to specialize in colon and rectal surgery to give the top level care that we can. We're very unique in the sense that our division is actually the only one in the state of New Jersey that trains board-certified colon and rectal surgeons, and in fact our program has trained 1 in 3 board-certified colorectal surgeons throughout the country.
Oh, wow.
So we have an expertise in all levels of colon and rectal care, predominantly cancers, but we also treat things such as Crohn's disease, ulcerative colitis, as well as cancers.
Yeah, wow. I am, first of all, totally amazed about the vastness and the enrichment of your department, and that it's so, that you do so much. And that your educational program reaches and has such a wide dimension there. So congratulations.
Well,
and I presume it's still growing.
Well, we continue to train surgeons to become specialists, and the nice thing about this is that the people that have come through our program have gone through 35 of the 50 states in the United States, so they kind of have spread the information that we have brought through Overlook and our fellowship training program.
Well, then we are very fortunate indeed to have Overlook Medical Center and your department being a nation leader in this area. So once again, congratulations.
Thank you.
Okay, so our topic is a serious one, colon and rectal cancer. So let's start off by your explaining exactly what that is so our audience knows what these awful illnesses are.
Well, cancer in general is an uncontrolled and abnormal growth of abnormal cells in a particular part of the body. In our specialty, we're focusing on mainly the large intestines, or what we call the colon. If I can reference the chart here, when we eat food obviously goes down through the mouth, down to the esophagus, and passes through the stomach, and it advances through 10 to 15 feet of small intestine where all the nutrition is absorbed. What does not get absorbed gets advanced into the colon, which is also known as the large intestine, and it goes up the right colon, across the transverse colon, down the descending colon, around the sigmoid, and out the rectum, which is the lowest portion of the large bowel. as you mentioned earlier, as we become older, roughly 1 in 20, 1 in 22 of us will develop a colon or rectal cancer. And although that is potentially intimidating when we first hear that, most of these can be prevented with appropriate screening. And when caught early, a cancer is completely curable without the need of any colostomies or ileostomies with this.
So when you say cancer, what does that mean? Is there a tumor in the colon? Is there a cyst in the colon?
Okay.
What exactly is a cancer in the colon?
So what we know is that most people who develop a cancer, which is a malignant tumor, first develop a benign growth called a polyp.
Okay.
A benign polyp is just the early presentation of an abnormal cell, which starts to grow. Fortunately, only 1 in 5 of us will develop a polyp, but the feeling is that polyps that progress over years will degenerate into a cancer.
Okay.
And these polyps can occur anywhere throughout the large colon.
Are they in the interior of the colon, or on the wall of the colon, or the exterior of the colon?
So
where are they?
Inside the colon. If you picture the colon as a tube or a tunnel, they are on the inside wall, and they initially tend to grow outside or project inwards like a mushroom would kind of project out with a stem and a top there.
So, so you said that they start off as a polyp, or would that be a cyst? Another word for that be a cyst?
Well, that's a cyst. Typically, in a medical interpretation or dictionary, would generally imply a structure that contains fluid in it. This is more of a solid growth.
Oh, okay.
And it has tissue all the way through it, and generally does not have any fluid in it. And it generally starts off as 1 to 2 millimeters in size.
Oh, that's very small.
Very small. And as it becomes bigger, the chances of it degenerating to cancer increases.
And if it's not caught, does that mean it metastasizes?
Sure. Well, fortunately for polyps, the feeling is most polyps take several years to degenerate into a cancer. And then once a cancer forms, even if caught early, 95% of the people can be cured and return to normal function. But once patients start having symptoms, that's when it's a little more fearful for us as well as them, because they're still curable, but it generally requires a much more aggressive treatment.
Okay. So who is at risk to get these tumors or polyps that you talk about? Are there certain people who are more likely to receive these or get these things?
Well, what we try to keep in mind is that everyone is at risk. As you mentioned before, 1 in 22 of us will get colorectal cancer. And that's the patient who has no family history, no symptoms at all. So everyone is at risk. The people who are at greatest risk are those who have a family history of, let's say, one family member who's a first-degree relative, like a parent or a sibling. That may double or triple your risk. If you have 2 or more, it can quadruple your risk. And so those are high-risk people who also have other associated medical conditions like colitis, ulcerative colitis, Crohn's disease, or they may actually have other types of cancers, such as uterine or ovarian or kidney cancers, which may then be associated with a genetic predisposition for colon cancer too.
Well, it sounds very ominous for people who have had that in their family. So I suppose a message would be that if you have had that in your history, that testing is going to be one of your most important factors here.
Sure.
Yeah.
Again, most people can be adequately screened, and colon cancers can be prevented. But what we know is that throughout the United States, over 30 to 35% of the people don't even get screened.
Oh, dear, yeah.
And as you had brought up before, as we had discussed, that colorectal cancer in those age over 50, predominantly because of aggressive screening and awareness, we've seen a decrease in the incidence, perhaps 2 to 2.5% a year over the last decade.
Are you saying that as people age that there's a greater chance of they're developing a colorectal cancer, that a younger person has less risk involved?
Absolutely. So what we know that as our age increases, the risk for colorectal cancer increases as well. And this ties into some things that we believe may be affecting the development of it. Ultimately, we believe that the cancers start off from damages or mutations that occur in our DNA, which causes abnormal growth. Mm-hmm. And as we get older, there may be environmental factors, patients' personal habits that can contribute to increasing these risks.
I was going to ask you about that. You always hear about smoking. Are there other factors in the environment that could take a polyp and make it deteriorate?
Sure. So smoking is a big risk factor for most cancers. And in fact, a recent NIH study suggested that 11% of colon and rectal cancers are directly associated with smoking itself. Mm-hmm. So if you eliminate the smoking, you actually may decrease the colon cancer rate even more.
Are there any other environmental factors?
Well, so we know that other factors that are potentially environmental could be diet. So people who not just eat large volumes of red meat, but highly grilled or high temperature meats, like grilled, seared meats in excessive ways, they create some chemical changes that are potential factors which can degenerate factors in our DNA that can cause it. We know that people who maintain healthier diets with fruits and vegetables and increased fiber tend to have lower incidences of colorectal cancer. Personal factors such as inactivity can actually increase your risk. So it's important to exercise during the week.
You can't be a couch potato.
No couch potatoes. And tied in with that is that we know that with the lack of activity, people's weights may increase too, and that is a factor too.
So you're saying a person who's overweight, who doesn't get much exercise, who smokes, has a much greater risk factor.
Yes. Yeah. They definitely increase your risk, and if you look at them and they have a family history, that would be the highest risk.
Oh, that's the highest risk. Right. So those people must be very, very careful. Okay, you mentioned symptoms earlier. So what are the symptoms of somebody who might have this? I mean, it's hidden in your bowels. I mean, how does one understand that they might have a colon or rectal cancer forming?
Sure. Well, the most common sign of a significant polyp that may be at risk to become a cancer or the development of an early cancer is bleeding. And although most causes of bleeding from the colon is related to a hemorrhoid, the most common sign of a cancer or a significant polyp is bleeding. So when we say someone has bleeding, we don't want them to assume it's a benign process, and they should just get checked out just to ensure there's no abnormalities there.
Okay, if you talk about bleeding, there's two types of bleeding then. There's the type that if you did have a hemorrhoid, you'd see red blood. Or if it's internal, would it be that your bowels turn dark because it's darker blood?
And sometimes, so as you point out, when it's lower down in the hemorrhoids, the blood is brighter or redder. It could be darker if it comes from the stomach, like an ulcer, or it could be red if it comes in the first part of the colon, because by the time it makes it down, the body oxidizes the blood and it becomes darker. But there's another point, as we talked about before, is that the occult blood, meaning there's chemically positive blood in your stools that a lot of times your primary doctor would evaluate you for. And if we see blood on what they call a hemocult test, then that's a sign that there might be something on the right side that's beginning to start that we just can't pick up yet.
Okay, so a bleeding, whether it's darker stools or red, is one of the symptoms. Are there any other symptoms that we should look for?
Sure. So again, our goal is to look for people before they have symptoms, but unfortunately, like we say, 30% of them never get screened. So when patients start describing altered bowel habits, they're more constipated, or they have diarrhea, or they have mucus in their stools, or they see the caliber, the width of the stool changing, those are all signs that we are concerned about. And finally, one of the biggest signs that concerns us is weight loss, unexpected weight loss.
Okay, weight loss. So if you unexpectedly lose 5, 10 pounds, maybe even 15 pounds, but in a short period of time, are you talking about, or are you talking about over an extended period of time?
Well, certainly we've had patients who've lost 10 pounds over a matter of a couple of months.
Oh, okay.
That's significant.
And they're eating normally?
They're eating normally, but they may have a absorption problem or a tumor that's competing for the nutrients.
Would they necessarily show darker stools at the same time?
Not necessarily.
So then the symptoms can be masked then?
They can be masked or they can be hidden. Certainly, if a growth is closer to the exit point here, it may be more noticeable, but if it's more on the beginning of the colon, it may be masked.
Okay. If you feel that you have some symptoms, then what would you do? Who would you go to? Who would you refer yourself to?
So a lot of patients will speak with their primary physician, who will then guide them in the right direction for screening, or many patients come to a colorectal surgeon or a gastroenterologist to have their colon screened. And if they have symptoms, and certainly of an older age group, a colonoscopy is generally warranted.
Okay. So colonoscopies, a lot of people have heard about them. A lot of people want to avoid them. They feel that they're yucky, that they're a pain in, not the neck, and feel that that's one procedure that they should not have if at all necessary. But your message here is that colonoscopy is a wonderful treatment tool and not to be avoided, not to be looked on with disdain at all, right?
Right. And the process of a colonoscopy is a lot different now than it was just 5 or 8 years ago. For instance, the bowel preparations are much better now, so it's not as harsh on your system.
Why don't you explain what the process for a colonoscopy is then?
Okay. Well, before a colonoscopy can be done, to obtain the best visualization with a colonoscope, it's important to clear out the GI tract so we can see polyps and look behind the different folds as we go through the colon. And a bowel preparation is necessary, and it's generally a laxative that you generally take twice before the examination. And there are a broad variety of laxatives that patients can choose from, and an endoscopist will generally select what his or her experience seems to be best. So the agents these days are much less harsh than they were before. Before, they would be much more like almost like a grenade went off you, and you would take it and it would just fly out of you.
Oh my gosh, yeah. And then you're in that bathroom all the time.
Right, and there you have the cramps and you just don't feel good. But now the agents now are much less harsh, and some people think, geez, when is it going to even work? And then it kind of starts to work more gently.
So in other words, what you do is you take a fluid, a laxative, or many times you prescribe something that a person takes the night before you're having the procedure. And what that means is that you have to go to the bathroom and clear everything out of your your large intestine.
Right. And again, because it's not as harsh, it's not as uncomfortable as well.
Okay. And then you've taken all that and your body is supposedly clear. Then what happens? You take over, right? Right.
So when you come to your facility, and when you come to Overlook, you come in, we get registered and admitted, and then you'll see an anesthesiologist, like most places, and they'll give you sedation to have the colonoscopy done, intravenous sedation, where you're very comfortable. And it's the type of medication when after the procedure you're not hungover and you don't feel lightheaded or dizzy, and most people recover very quickly right afterward. And during the test itself, we use a flexible tube with a video camera on it that is high definition, so we can look throughout the colon. And if we see a polyp, we can remove it then
Right
at that
then and
time.
there?
Absolutely.
So what you're doing is you're taking something with a filament, and on the tip of it there's a light, there's a
Right.
camera, and there's a scissors?
So there's, right, so it's a round tube, like you say, with the filaments that give you a high definition image. There's a light on it, and then there's a third opening which allows the advancement of a instrument that can remove polyps or biopsy polyps.
Okay, so you travel up the large intestine, and do you go through the entire intestine?
Right. So when we do the colonoscopy, we start at the end, and then we go up all the way around until we reach the beginning of the colon. And we know we reach the beginning of the colon when we identify the opening of the small intestine and an ileocecal valve in this area, and we see where the appendix is.
Okay.
So we look at the entire colon.
Okay. So that's wonderful, and it sounds like that's an advancement over the past where you really didn't have as good a view, if I might say, as you do now.
Sure. The view is tremendous now with the high definition instrumentation, and the comfort level is better too, because we use something called a CO2 scope, a carbon dioxide scope, where in the old days, many places had just regular air that was pumped in, and that's what made people crampy, uncomfortable,
bloated. Yeah.
And now with the
I got it.
CO2 scopes that we have, it's very uncommon to feel bloated after the exam because this carbon dioxide is absorbed rapidly, and as you know, we breathe out carbon dioxide.
Right. So, Dr. Chinn, when you're in there and you yourself do these procedures, and you're removing or cutting off these polyps as you go around, do they excrete themselves, or?
Oh no! When we
remove
remove
them?
we capture them and we
You
send
capture
them.
them.
We send them for biopsy.
Oh, you send them all for biopsy?
Because not all polyps, and this is important, not all polyps are the type that will progress to a cancer, but we wouldn't know until we remove them.
Okay. And if you did a colonoscopy without removing polyps, there's still that risk that this polyp over the years, and this is what you said earlier, a polyp over the years could degenerate into a cancerous tumor.
Right. So in most people who develop a cancer, a polyp may take 8 to 10 years to degenerate. So we try to get everyone at age 50, which is the standard guidelines, but if someone comes in at 51 years and is not having any symptoms, they're generally they should still feel comfortable about coming in to be screened.
Okay, so your message here is that everybody over 50 should really think about having a colonoscopy done as one of their standardized exams.
Right.
And if they have a polyp, it will be removed, which gives them a greater chance of not developing colon cancer.
Absolutely.
But you know, doctor, people avoid this because there's this perception outside there and our audience that this is a yucky test to do. But speaking from experience, I can tell you that it was not at all. It was fine. The preparation was not difficult. The recovery, didn't even know that the procedure was done. The recovery was easy. And it made me feel better to know that I'd had this done.
Yes, the colonoscopy is a test. The apprehension and the fear is much worse before than going through it.
So we're telling everybody, do not hesitate to schedule a colonoscopy if you're over 50 and or you have a family history of this. So besides colonoscopy, are there other things that a person can do to prevent this type of cancer?
And this ties in well with other risk factors and things that you prevent. So for instance, let's say you have a family history, which we talked about before. Those people should start at age 40 or 10 years earlier than the youngest member in your family who had colon cancer. And the reason that's important is there are now some tests available that are home kits, for instance, and there's a home kit made by Cologuard, which some people use, but those are only for people who don't have any family history and do not have any symptoms. And that test is an emerging test, and it utilizes molecular markers, or it looks for genetic material that gets excreted in your stools. So patients who have no family history, they may utilize that test.
You see it advertised at TV all the time
It's
now.
advertised, and it's about 90% accurate. But if there's a family history or you have symptoms, it is not recommended for that. In fact, your insurance company will not approve of that for its use. Because if you have symptoms or there's a family history which increase your risk, that 10% margin is too large to accept. So then you should have a colonoscopy.
Okay, what about your lifestyle? You talked about smoking and people who are overweight. Should one try to improve?
Sure, absolutely.
Your body factor?
Right, absolutely. It's personal habits are important. So smoking, as I mentioned before, it's felt that 10 to 11% of colon cancers are a direct result of smoking. So we should stop smoking.
Every doctor I speak to says that, number one. And about sedentary lifestyles, those couch potatoes off
sedentary,
the couch.
we should be getting over 100 minutes of exercise every week.
Okay.
It's hard to do in our society.
But take a walk, right?
Take a walk, take a couple walks. Take that extra lap around the neighborhood.
And watch your diet. You talked about red meats. It doesn't mean that you can't have red meat, though.
No. You can still have red meat, but just do it in moderation. A lot of plant-based foods are good too. Fruits and vegetables are important. Unprocessed fiber is very good, very healthy for you. Okay, so those are important things. The diet, the high calcium diets may be protective. And actually what's interesting, other than diet, is taking an aspirin or some NSAIDs sometimes are helpful. The balance is that sometimes those can be upsetting to your stomach. And typically you need to take them consistently for several years for it to have a protective effect. But if someone's already taking an aspirin a day for their heart, they're probably adding some colon protection too.
Okay, well, Dr. Chinn, this has been wonderful to hear about the description of what colon and rectal cancers are, what some of the symptoms are, and of course what some of the preventive treatments are. And we appreciate your being here very much. But I think our biggest message is, don't be afraid to have a colonoscopy done.
Right.
So thank you so much for joining us today on 30 Medical Minutes.